Good afternoon or good morning, everyone, and welcome to today's webcast on introducing the new CAHPS Clinician Group Visit Survey 4.0 beta version. My name is Dale Schaller, and I'll be moderating our session today, which is presented by the Agency for Healthcare Research and Quality's CAHPS User Network. Our webcast today will cover the following major topics. We'll start with a brief overview of AHRQ's CAHPS program, how AHRQ has been responding to the COVID-19 pandemic, what has been the CAHPS team's approach to assessing patient experience in a very rapidly changing healthcare landscape, and then we'll focus on a description of the new CAHPS Clinician Group Visit 4.0 beta survey, how it was developed, how it's designed, and how it compares with the 3.0 version of CGCAHPS. That does sound like a lot of material, but our hope is to leave as much time as possible to field your questions and answer as many as we can over the next hour. Which takes us to the few sort of housekeeping details we'd like to cover before we begin. One has to do with if you're having difficulty with your audio, you can change the audio selection so that WebEx calls you back, and then you can connect through your phone instead. If your computer slows down or freezes during the presentation, you can try logging in and out just to refresh the page. But remember, this might just be related to the internet connection speed that you're experiencing on your own computer. If you need help at any time during the webcast, you can use the Q&A icon that we'll show you right now on the next slide, which you can use. We encourage you to use this if you have any technical difficulties, but more importantly, if you have a question for our speakers, we would encourage you to ask your question through this feature. And so depending on the browser that you're using, your screen may look a little bit different, but in any case, look for the Q&A icon at the bottom right-hand side of your screen, and be sure that the drop-down option displays all panelists so that we can see your question. We also ask if you're willing to share your name and your organization so that we know who you are as you submit your question. So today's session is being recorded, and a replay of the webcast and the slides will be made available on the AHRQ website in the very near future. So I'd like to welcome now and introduce our speakers for today's webcast. We're going to begin with introductory comments from Karen Ginsberg, who directs the Agency for Healthcare Research and Quality's CAHPS program, as well as the Surveys on Patient Safety Culture, or SOPS program. In her position at AHRQ, Karen focuses on program development, implementation, operations, and evaluation. Karen will be followed by Ron Hayes, who is a professor in the UCLA Department of Medicine and has served as a principal investigator on the CAHPS team for the RAND Corporation since the very beginning of the CAHPS program in 1995. We'll then turn things over to Stephanie Fry, who is a survey methodologist and a senior study director at WestAT. Stephanie serves as the lead on the CAHPS instrument team, which is charged with development and testing of CAHPS patient experience surveys. And again, I'm Dale Schaller, been a long-time member of the CAHPS Consortium, serving as your moderator today. And with that, I'll be pleased to turn it over to Karen.
Good afternoon, everyone. This is Karen Ginsberg, and thanks, Dale. I'm excited to present today's material, today's webcast to you on our latest survey. I wanted to point out that 45% of the registrants for this webcast are brand new users to CAHPS, have never used a CAHPS survey. So we have a lot of new users. The others have had varying levels of experience. And so I'd like to welcome everybody, and I know that everybody will find something new in today's material. Thank you for submitting your questions to us when you registered. We think we're going to answer many of the questions today, but if we don't, please contact us at our technical assistance line. You'll see that at the end, and ask your questions specifically, and we'll get back to you. Could I have the next slide, please, Michelle? So I want to just talk a little bit about what the Agency for Healthcare Research and Quality is. We're a research and development agency. We're a science-based agency, and what we do is invest in research and evidence that makes healthcare safer and improves the quality of healthcare that we receive. So as such, we create tools for healthcare professionals to use to improve care for their patients, and we generate measures and data that are used by providers and policymakers and researchers to improve the performance of the healthcare system and then evaluate the progress of it. And we feel it's a priority of AHRQ to push our science to implementation and get our tools and products to you, our users. So I want to stress that we are a research and development agency, and we get a lot of questions about this. We're not a regulatory agency, and so we don't run programs that require the collection of CAHPS data. And a lot of people always have questions about program requirements, and if you do, you need to talk to the agency that implements the program that you're participating in. For example, the Centers for Medicare and Medicaid Services has a lot of programs that require the collection of CAHPS data, so you'd need to get in touch with them about specific program questions. Could I have the next slide, please? Thanks. So CAHPS stands for Consumer Assessment of Healthcare Providers and Systems, and the program is a program to advance the understanding and the measurement and the improvement of patients' experience with their healthcare. We are celebrating our 25th anniversary this year. We're a mature program that's been around for a long time, and Dale has mentioned the CAHPS Consortium. This is the body that is responsible for the technical oversight of the program, the CAHPS program, and the technical quality of the surveys. And the CAHPS Consortium consists of staff from AHRQ, from the Yale University School of Public Health, RAND Corporation. Yale and RAND have cooperative agreements with us. Westat, our contractor, and as well as our subcontractors to these organizations. Next slide, please. So a little bit about the CAHPS research and products. We have a very active research program that focuses on understanding patient experience, how to measure it, and also on the best methods to implement surveys. And that's all in addition to the work that we're known for, which is developing surveys on patient experience of care. And so, you know, I want to point out that we have been conducting for a long time research on the best ways to implement surveys. And historically, we hadn't made this an end product for our users in and of itself, but it's becoming more critical to have this information out to our stakeholders. Questions of electronic survey administration, for example, are always coming up. So we've started putting the research that we've been doing on our website, so it's there, and if you can't find it, drop us a note and we'll help you find it. We want to explain the work that we've done in this area to you. How about the next slide, please? Thank you. So a little bit about the CAHPS surveys. You're going to hear more. They are recognized as the gold standard for patient experience measurement because they capture the patient's voice and in the development of the surveys. That's a really important focal point of the survey development. Surveys are developed using standardized methodology and research findings. They measure experience of care in different settings and with health plans and with programs. And the surveys are trademarked, and the trademark, which is held by AHRQ, ensures that the CAHPS design principles have been met so that they can be considered a CAHPS survey. And then the CAHPS Consortium is very heavily involved in making sure that the survey design principles are adhered to for any CAHPS trademark survey. Next slide, please. So let me just tell you a little bit about the context for the development of the survey you're going to hear about today. AHRQ very early established a process for responding to the COVID-19 pandemic. We established a strike team of senior researchers and leaders within the agency, and that team developed short, immediate, and long-term approaches to the COVID-19 response and the recovery effort. And then together with the AHRQ's National Advisory Council, they and the strike team identified areas, specific areas where AHRQ could help accelerate the response to the pandemic. And they identified about 7 or 8 different areas, one of which had to do with the healthcare system's response and the expanded use of telehealth. So the survey that you're going to hear about today is one product that's in support of this specific response. So we have a lot on the website. You can see the link there. Feel free to go take a look if you want to learn more about what AHRQ did in response and continues to do.
The link is provided on slide 11 at www.ahrq.gov/coronavirus/index.
So just finally, I just want to mention, in addition to the work you're going to hear about today, the new survey, we've also done a little bit of work on some of our other products. We've updated the health plan survey to version 5.1 to include wording. This is not a new survey. This is just an update in the wording to incorporate a more heavily telehealth environment. We worked with NCQA on this. So if you have questions about this survey, you can look at our website. You can look at NCQA's website. I know they have a big rollout of the information. We're also updating the clinician and group surveys to 3.1, also to accommodate a more heavily telehealth environment, including our patient narrative supplemental items. So you'll hear a little bit about that today. So thank you so much. I'm going to turn this now over to Ron Hayes to talk about the guiding concepts for the new CAHPS survey. Ron?
Okay, thank you, Karen. Let's just go ahead and jump to the next slide, Michelle. The first CAHPS survey was developed actually in the 20th century, and it was targeted at health plans. There are now a variety of CAHPS surveys, as you can see here. Some, such as the hospital survey, assess facility care. Others, such as the cancer care survey, assess condition-specific care. The clinician and group survey that's highlighted here assesses ambulatory care. Next slide, please. So the CAHPS Clinician and Group Survey 3.0 was released 5 years ago. So I'm giving a little history now. That survey asked about experiences with primary and specialty care delivered by medical groups, physicians, and other healthcare providers during the last 6 months. The 3.0 survey was a revision to the previous 2.0 survey by adding a care coordination composite and eliminating some of the items in the access and communication composites. There's a version of the 3.0 survey for care delivered to adults and another for care given to children. Next slide, please. So the 3.0 survey assesses access to care, communication from providers to patients, care coordination, and office staff, courtesy and respect. It also includes an overall rating of the provider. The 3.0 survey has been used for a variety of purposes, including quality improvement, choice of providers, public reporting, value-based purchasing, and recognition and certification programs. Next slide, please. So the CAHPS team updates surveys as needed. The primary driver of the new Clinician and Group Visit 4.0 beta survey was the rise of telehealth in association with the COVID-19 pandemic. The new survey makes it possible to monitor patient experience with care associated with the changes in healthcare delivery. Next slide. So the new 4.0 survey, like the 3.0 survey, can be used to assess primary and specialty care. The new survey assesses phone and video visits as well as in-person visits. It asks specifically about the most recent visit rather than care over the last 6 months. And as a general note, all CAHPS surveys are designed to focus on aspects of care for which patients are the best or only source of information and that they have experienced. Next slide. So the CAHPS survey development process includes a series of steps that are shown here, beginning with a review of the literature to see what has been done before. We also obtain input from stakeholders and technical experts. In addition, we conduct focus groups to identify what is most important to patients. And after drafting survey items, we evaluate them using one-on-one cognitive interviews and revise questions as needed. The final step, which is yet to be done for the new survey, is field testing to evaluate its psychometric properties. So now I'll turn it over to Stephanie.
Thanks, Ron. Appreciate it. And I'm going to take the next few minutes to walk through the steps in the development process that led to the Clinician Group Visit Survey 4.0 beta, and to provide some detail about what exactly that survey looks like. So in keeping with the process that Ron just reviewed, the Clinician Group Visit Survey 4.0 followed the CAHPS process, starting with a literature review where we looked at use of telehealth in ambulatory care, how telehealth approaches are integrated into care delivery, and patient feedback about telehealth. We also collected many in-use or under development surveys about telehealth. All of these materials were reviewed to identify how care delivery would look different when integrating telehealth and how this could impact patient experience of care. We continued our development with several rounds of expert interviews. Our interviews included healthcare providers, health systems and payers, leaders from several government programs, academic stakeholders with interests in healthcare delivery and patient experience measurement, and other users of CAHPS ambulatory surveys. Through these interviews, we detailed how healthcare delivery was changing in the United States, again with the integration of much more telehealth, and the perceived impact on patient experience, as well as informational needs regarding quality of care and patient experience in this new healthcare delivery model. We drafted a survey with several iterations and revisions, and then we conducted 4 rounds of cognitive testing, including both English and Spanish-speaking participants, and participants with a wide range of demographic and geographic characteristics. After each round of cognitive testing, we reviewed the results, and the survey was updated and refined so that the language more clearly conveyed the concepts and so that they were understood uniformly across different respondents. You saw this graphic earlier in Ron's slides, and I want to draw your attention to the final step, the field testing. As was mentioned, this is where we are now with the CAHPS Clinician Group Visit 4.0 beta survey. The survey has been released and is available on the AHRQ CAHPS website, but it's a beta survey and it does not yet have the CAHPS trademark as field testing has yet to be completed. Getting now into the nitty-gritty of the Clinician Group Visit Survey 4.0 beta. This survey instrument can be used to collect patient experience data across visits of all types, whether they be in person, by phone, or by video. Using one survey to assess patient experience, regardless of their visit mode, allows for comparison to understand if patient experience may be different depending on the visit mode. For example, does a patient have a different experience if they're visiting the same practice or the same provider in person versus if they have that visit by video? The survey assesses patient experience with a named provider. Using administrative records, ambulatory practices or groups, insert the name of a physician, a nurse practitioner, or another provider with whom the patient had a healthcare visit. Where you see here, it says, it's got a placeholder for name of provider label goes here. That would actually be replaced with the actual name of the healthcare provider. That provider then is referenced through the rest of the survey as the patient responds to questions. The survey assesses the patient's most recent visit with that named provider. This prompts the patient to report about a single encounter, describe the mode of that visit, so in person, by phone, or by video, and respond to questions about their experience during that specific visit. The visit survey does not ask about patient experiences with asynchronous care, for example, remote monitoring, or patient and provider interactions that are not in live time, such as emails, texts, or other interactions that happen through an electronic portal. The Clinician Group Visit Survey 4.0 Beta includes questions that address 4 main areas. They're called out here by their formal name. These are proposed domains to look at getting timely appointments, care, and information, how well providers communicate with patients, providers' use of information to coordinate patient care, helpful, courteous, and respectful office staff, and then there is a patient rating of the visit. The visit survey uses an expanded yes-no scale, which is appropriate for measurements in the visit context. This is to say, because a patient experience with a particular event likely only occurred once or a small number of times during a single visit, the survey uses responses of yes, definitely, yes, somewhat, or no to understand how that patient experience went during the visit. We're calling these proposed domains since the field testing data are needed to confirm whether the items will hang together analytically. And additionally, consumer testing will be conducted to allow us to finalize these domain names to ensure that they are clear and a meaningful representation of the questions in the survey that they represent. For those of you who may be familiar with the Clinician Group 3.0 version of the survey, we wanted to provide a little bit of a comparison of how this new 4.0 beta visit survey compares to the Clinician Group Survey 3.0 that you may be familiar with. Development of the visit survey 4.0 is still in progress, with field testing pending, and as a result, the trademark is also pending. In comparison, version 3.0 of the Clinician Group Survey has been fully developed and tested and approved for use of the CAHPS trademark. Depending on your intended use, this may be an important distinction. For high-stakes use, it may be important to use the trademark 3.0 version. However, if your goal is internal quality improvement as your practice explores best ways to deliver telehealth, the 4.0 beta version may be preferable. At this time, there is only an adult version of the Visit 4.0 survey. A child survey version is under development, but in the early stages. In contrast, there are both adult and child versions of the 3.0 survey. Both surveys are available in English and Spanish. As with all CAHPS surveys, both the Visit 4.0 and 3.0 versions of the survey are intended to be compatible with supplemental items. And for those new users, Karen reminded us that there are a number of you. Supplemental items are additional survey items that you can add to the CAHPS core to either drill down on or get additional information about particular areas that may be of interest to you. These may be CAHPS prepared supplemental items, or they could be your own, what we refer to as homegrown supplemental items. So what we're referring to in this table here is there's a database of CAHPS supplemental items that are available for the 3.0 version of the survey. There are also beta versions of a narrative item set that is applicable with the 3.0 version of the survey, and narrative items are open-ended survey items where you can get free-form feedback from patients about their experiences rather than close-ended responses. So those things are available in conjunction with the 3.0 version of the survey. We're not quite there yet on the 4.0 visit survey. However, there are narrative items under development for the 4.0 survey, so they would be in the coming soon category. To support CAHPS surveys, AHRQ also makes available guidance documentation in conjunction with the surveys. The Clinician Group 3.0 survey has a full set of guidance document available, including information about best practices. Karen referred to AHRQ being a science-based agency, so this wraps up that information about best survey science with regard to survey preparation, fielding, data collection modes, and reporting. In contrast, the Visit 4.0 version has limited documentation as final development steps are still pending. As a reminder, the Visit 4.0 survey is still in beta form. The survey is recommended for use in quality improvement and internal uses, but would not be recommended for high-stakes use such as public reporting or pay-for-performance. For those types of uses, the Clinician Group 3.0 survey with the trademark would be recommended. And finally, at a more granular level even still, this shows a comparison, again, of the Visit 4.0 beta survey and the 3.0 version of the survey. The Visit 4.0 survey focuses on patient experience of care with a named provider at a most recent visit, so just that one instance, while the 3.0 version asks about experience, again with a named provider, but over the prior 6 months. The visit survey has 24 core items, plus 9 additional demographic questions, and that includes questions about visit type, so whether it's in person, by phone, or by video, and the efficacy of the visit technology. The 3.0 version has 22 items, plus again 9 demographic questions, and it does not give you information on visit modes. While the composites or the topics that are covered are the same for both surveys, the approach to each is a little bit different. As you could imagine, if you were asking just about the most recent visit, the things you could ask about and the ways you would want to ask those would be slightly different than if you were asking about experience over a longer period of time, 6 months. So while the topics covered are the same, the number of questions or items differs slightly between the visit survey and the 3.0 version of the survey. Additionally, the visit survey collects at the end a rating of the most recent visit on a scale of 0 to 10. In contrast, the 3.0 rating is of the provider, him or herself, again, on a scale of 0 to 10. If you didn't document everything we just threw at you in the last half hour in this sort of high level down to deep dive overview of the new CAHPS Clinician Group Visit 4.0 beta survey, don't worry. A replay of this webcast will be available in the coming weeks, and there are many materials already available online for you. Please do visit www.arc.gov/CAHPS. There you will find a wealth of information, including surveys, user guidance that I referred to, including information about sampling and data collection, all sorts of things. A description of the development, so detailing how the CAHPS Consortium walked through the steps in developing both the 4.0 visit survey as well as the 3.0 and back further from there. It provides a comparison of the Clinician and Group Survey versions, so the 4.0 visit versus the 3.0. And as I said, this webcast replay and the slides from this webcast will also be coming soon to that website. I'm going to turn it back to Dale now to lead us through some questions that we have from the audience.
Yeah. Well, Stephanie, thank you so much for a really great overview of this new survey in its beta version, and also to Karen and Ron for setting the stage for all of this content. We're now open for Q&A. We actually have been, and again, just as a reminder, to submit a question, you find the Q&A box, type it in and make sure that all panelists are selected so that we can see your question. And if you are willing to identify yourself, that always helps us to kind of relate the answer to who you are in the organization that you're representing. We've had a number of questions that have come through thus far. I'd like to start with one that came from Andrew Orozco from the Sacramento Native American Health Center, who tells us that his health center has already agreed to move forward with 4.0 and plans to roll it out to patients this coming week. He says they felt 4.0 was more reflective and appropriate for what happened in 2020, and we can all agree that a lot has happened in 2020. Is that okay? Ron, you sort of prefaced description of the survey with the environment in which it was developed. Do you want to respond to the question of appropriateness of the new 4.0 survey?
Yes, I think that's a very simple answer, and that absolutely that is correct. And that's the whole reason it was developed, was to reflect what's going on with the pandemic and its association with the increase in telehealth visits. So that's the reason we developed it, and we believe it's very appropriate for this environment.
Yeah, and I would just add we're really pleased, Andrew, that you're going to move forward with it. And we would love if you and anyone else who is planning to use the survey in its current beta version to please keep us informed of your experience with the survey. Okay, another question to you, Stephanie, is related to the languages in which the cognitive testing was conducted. You mentioned English and Spanish. The question has to do with other languages such as Mandarin or Cantonese. And if so, if any potential barriers have been identified with those other languages.
Thanks, Dale. And our cognitive testing was limited just to English and Spanish. AHRQ makes the CAHPS surveys available in both English and Spanish. We know that from there, as some different organizations and agencies have adopted CAHPS surveys for their own use, they have sometimes then translated it into different languages to fit the needs of their constituents and to make sure that the survey is available in languages that meet their market needs. But we did not test in any other languages other than just English and Spanish. So I can't speak to any possible limitations there.
Thank you. Our next question has to do with plans and timelines for field testing. And I'm going to pitch this one to you again, Ron, to address the plans that AHRQ has, if any, for field testing, and how other organizations may decide to go ahead and do their own testing.
Okay, so AHRQ is not officially doing field testing, at least as yet. And we're aware of organizations that are already in pilot testing mode or planning to do that. So a formal field test has not been planned yet, but we're very interested in any organizations that can administer the new survey. And if they can let us know about their intent, anything that they, in terms of feedback they want from us, and also if they're going ahead with it, their results would be very helpful to our continuation and advancement of the survey.
Great. Thanks, Ron. Stephanie, the next question relates to the look back period that was chosen for the new visit survey. Can you describe again why move from a 6-month recall period to the most recent visit?
So this comes as a result of the feedback that we collected from users, and in trying to figure out how do we how do we use this survey to assess the impact of telehealth? And we know that people oftentimes will have many different visits using many different modes over the course of time, even with a single provider. So while an initial assessment may be done by a video visit, there may then be an in-person follow-up visit, and those experiences may look really different. And so this survey was designed specifically to be able to unpack those pieces. So if you put them all together with a look-back period of 6 months, even for a single provider, you may get a mix of reports about, well, this visit was good and overall their communication was okay. It was really good when we were in person, but it was really challenging when we were doing a video call for whatever reason. And so in order to really get a clear picture of how the different experiences could look different by mode, if they did, we felt we needed to split them all apart. So it's the single survey that applies across any of those modes of care delivery. But with a look-back period of just the most recent visit, you then get one mode. So it's either an in-person visit and a report from the patient's experience about that, or it's a telephone visit with the report of the patient experience by that, allowing for that comparison to happen.
All right. Thank you very much. Ron, the next question comes from Jeff Palawoda from Quality Data Management, or QDM. It actually packs a couple of different issues together. So the question is, they currently feel the 3.0 version for their clients, but they want to assess telehealth. And the question is, can they integrate the telehealth questions into the 3.0 version, and how does that relate to the trendability with the current use of 3.0, and how might that relate to 3.1?
So they actually asked about 3.1 survey? That's what you're saying at the end?
No, I'm actually adding that as a little editorial.
Okay, yeah, because that's what I was going to focus on. So as Karen alluded to, there is a 3.1 survey forthcoming where it will have instructions to allow respondents to think about all types of encounters with providers, so telehealth as well as in person. So that would be one way to go for sure. But even there, if you do that and you want to compare it with 3.0, we have a little data that suggests that you might get more inclusion by having instructions to tell people to think about all types of visits. And given, the changes that are going on now in healthcare delivery, there should always be some caution in trending. But I think you would at least want to try trends and see if it's possible, but you'd have to be careful because there is so much going on that, you can't be certain that what's really contributing to differences.
Great. Thanks, Ron. So Karen, I want to bring you into the conversation, and I think that's a question that you might want to answer related to plans or consideration for creating a pediatric version of the new 4.0. The organization is Research and Marketing Strategies, and the question has to do with having a number of pediatric practices that are currently using 3.0 that do offer telehealth visits. And obviously there's an interest here in being able to apply that to pediatric patients. So are you aware of any plans to develop a pediatric version of this survey?
Hi, can you hear me?
Yep.
Okay, good. This is on our list to consider. I think we want to do some background research first to understand what the environment is like and what it's going to take to develop such a survey. It's certainly on a priority list. I can't tell you when or how it will get done at this point, but we are aware of the interest in a pediatric version, and we're paying attention to it as best we can right now.
Thank you. So the question here I'm going to ask Ron to respond to a question from Brooke McEnroy from the Public Policy Center at the University of Iowa, who asks about any plans to expand questions regarding telehealth to any of the other surveys, such as the health plan surveys. Ron?
Okay, so you've already heard that the 5.1 health plan survey has already been done in collaboration with NCQA to make it applicable to telehealth visits. And then the Clinician Group 3.1 survey is doing something similar. So we're already in the process of doing that. I guess on top of that, it's a little bit more tentative, but the CAHPS team is thinking about at some point working on some telehealth supplemental items. There's no guarantee, I think, of that. Karen may have something to say about it, but we are also thinking about that possibility.
I think that's a fantastic question, and I think certainly considering telehealth supplemental questions is also something that we're thinking about. We just finished with this survey, so we're trying to figure out the priority list for how to move it forward, what the field needs. You know, it's helpful to us if you contact us and tell us what your interests are and write us a note and say, we really need this, and here's the reason why. You know, we want to be responsive, and it's really helpful to hear from you about what your needs are. So send us a note, caps1@westat.com, and just tell us what you're thinking about, what your needs are.
Thanks, Karen, and thanks, Ron. There's a question here from Cliff Rowley, and I think this has been answered, but I just want to raise it again to be sure. It's the question of consideration for moving into a 6-month framework. And I believe the answer is we're doing that with the 3.1 version of CGCAHPS. And I'm going to leave it at that. And if there's not clarity, Cliff, you can get back to us offline. Stephanie, it's a question I know that has come up during the development period of the survey since we participated in talking to a number of stakeholder groups. Could you just talk a little bit about the reasoning for taking the provider rating question out of 4.0 and replacing it with the visit rating question?
There was a lot of discussion around that. And where we landed with the rating question for the visit survey was because the survey was so carefully focused on the visit, we felt that that was the most important thing to measure there. And some of the feedback that we heard was particularly in early days after COVID-19 made its way to the US and practice policies around how care was being delivered changed so dramatically. There were many people seeing non-standard care providers because those were the care providers that were available. So their regular provider was doing something else, was not seeing patients, whatever it was. And so in many cases, people were describing visits that they had with a provider that they mightn't have known before. And so the rating would not have been an all-encompassing rating of that provider in any context. And in fact, we didn't want it to be, because if you ask about experience with this provider, 0 to 10, people really wanted to telescope back in time and tell you about kind of their whole history with that provider, if they had one, and provide a rating on that. And where what we were looking for was really limited to your experience with this visit, we had much more accurate and more meaningful feedback when we asked people to provide the rating of the visit.
Yeah. Thanks, Stephanie. I'm just going to push a little bit further, and another sort of issue I know that came up a lot during the development process. This has to do, it's a question from Ted Von Glahn related to care coordination and the extent to which in the development process, we assessed getting the visit summary into the patient's main medical record if a telehealth vendor was typically on the patient to do so. Not quite sure I understand fully what's being asked, but I guess I wanted to raise the question about how we grappled with getting a sort of our arms around care coordination and how that relates to, I guess, this internal process to getting the visit summary into the patient's main medical record.
Dale, I would say that would be a perfect topic for the supplemental item set. It's clearly not represented, as far as I can tell, in the new survey. We have two, like Stephanie said, we have 2 care coordination items, but they're similar to what we had before. So when we got really specific with telehealth questions, we have some of those, but that sort of thing, we can't, it has to be a short survey, so we don't cover great detail. But that would be a supplemental item set.
And I would add on to what Ron's just said. We heard from many people, particularly with telehealth visits, that care coordination was so important to make sure that kind of the follow-up pieces were happening where you wouldn't actually physically walk someone down and do a blood draw while they were there in the office. How do you make the rest of those pieces come together? And that in terms of overall care delivery, that was essential. And we heard that loud and clear. And one of the things that we bumped into was some of that doesn't fall into the category that Ron described during his presentation, where patients are the best or only source of that information. Patients, in fact, are not great sources of some of that care coordination information because it happens behind the scenes or should happen behind the scenes, and they don't know if it does or doesn't happen. Their experience is only what is reported to them, what they see if somebody shows them a record. So some of the care coordination pieces we're still working to refine to figure out how do we get the patient to report accurately on some of the pieces that they witness and experience directly.
Right. Thanks very much. Very helpful responses. I'm curious to know, Karen, is a question regarding the timing of adding the trademark onto the 4.0 version. Can you just address a little bit more what steps are required before that happens?
Sure, Dale. As we discussed, a survey is trademarked after the psychometric testing and analysis and extra consumer testing are finished. And so what the trademark really means is that you can use the survey and its measures for the really high stakes purposes of things like, public reporting or for reimbursement purposes or whatever. And so because we have the psychometric measurements, we've finished, we've finalized the survey based on the psychometric testing, the field testing. We've done our extra consumer testing of the labels Stephanie mentioned. And so after we review those aspects of development and the testing results, then we can think about awarding the trademark. So it's not going to happen until we finish the field testing, the pilot testing or field testing. I'm using those terms interchangeably.
Right. But one additional question here for you, Stephanie, I think, given your role with the instrument team, just a little bit more explanation of how the cognitive testing was conducted, how often it was done, and was it done for both versions? And I'm assuming they mean for both the 3.0 and 4.0 versions.
So knowing again that there are a number of people who are new to CAHPS, I'll take just a moment to describe what we do in cognitive testing. So we go in with a draft survey. We've got items that we think cover particular topics that we understand are of importance. And the goal through cognitive testing is to understand how people are interpreting the questions and how they're responding to it, so that we can see if people are understanding them the way that we intend, in terms of are they understanding the research question that we're trying to get at? Do they understand them consistently across different population groups. For example, do men interpret things one way and women interpret it a different way, or people in rural areas have wildly different experiences that don't sync with how they would think about responding to a question, in comparison to how someone living in an urban area might respond to that. So we try to get people representing a whole breadth of geographic and demographic characteristics. And we conduct a series of discussions to elicit from people, what did you think about to answer that question? What does that question mean to you? To get a sense of, are they consistently and clearly understanding the questions and using the response scales consistently? So we conduct rounds of that testing, and then we pause after we get to a certain number, usually around 9. We see what we have and we identify the areas. We know this question didn't work well based on the testing that we got from our first 9 respondents. Then we make a whole series of revisions to try to address the issues that have come up. And then we go back out with a new survey and a new set of questions, and we start again until we get to a place where we feel like the questions are understood clearly, they're understood in the way that they're intended, and people are using the response scales consistently. We conducted both English and Spanish language testing, knowing that an item that works well in English, once you translate it into Spanish, may no longer work well, and the language, in order to be consistent, might need to be revised across both survey versions. So we did 4 rounds of that testing through the summer primarily and into the early fall for the Visit 4. What became then the Visit 4.0 survey. We did not do testing of the 3.1 CG survey that is pending, and so you will see that will come out with that disclaimer as well. Dale, I think I answered the different pieces of the question you asked.
Thank you very much. I think it was a very helpful overview of what cognitive testing involves and why it's so important in the development of these surveys. So I just want to go back to a few questions that we were able to receive in the registration process. We actually got a lot of them. Many of them we have already addressed. One that came up a couple of times, Karen, I want to ask you to give a sense of what might be the prospects for the availability of comparative data through, sort of a CAHPS database version for the 4.0 survey.
Thanks, Dale. That's a good question. And I should mention for our new users that even though I said earlier that we don't require a collection of CAHPS data, we're not a regulatory agency, we don't have that authority, we do maintain databases for some of the CAHPS surveys for which data are voluntarily submitted. And we don't, as I said, we don't require it. We allow those organizations who collect data to, follow our guidelines if they'd like to participate and submit data. And we publish a yearly chart book of what we receive and provide a customized feedback for folks who are data submitters. So the rest of my answer is going to be what we talked about earlier. Like, we don't yet have plans for a database. We don't, we know that folks are interested. We've heard that some folks are interested. We don't have plans yet, but we want to be responsive to your interests. We'd like to consider this possibility, and we're interested in seeing what comparative data would look like too. So for those of you who plan to use the survey, let us know about your use of the data, how you might use a comparative database and the data from such a database if we had one, and why you would need it, and communicate back to us. If you use the survey, if you have specific interests in data or a version of the survey or whatever, let us know about it. We want to try to be as responsive to you to the extent that we are able. So we're waiting to hear from you. We hope you use the survey and give us some feedback. Thanks,
Karen. And I think that's maybe one of the most sort of overarching themes of where we are at this point. And what we've tried to convey in today's webcast is that we are on the cusp of, hoping that organizations will pick up the survey, begin to use it, monitor the use, share the results with us, keep in touch with us. I should mention too that in the scheme of things and in the sort of the context of the current pandemic environment that we're all sort of dealing with, this survey was developed in a sort of on a fast track basis in light speed, basically starting in the spring. And all of the steps that Stephanie and Ron and Karen have described to go into developing a survey happened in a very, very short time frame. And so we're really pleased with this product. We recognize that it is a beta version. We encourage organizations to take a close look, begin to implement it, and then we will be moving forward with the testing that needs to happen in order to make an official CAHPS survey with the trademark at the right point. So I know that we're close to the end of the hour. I want to thank everyone for attending today's webcast. I think if we can move on to just a couple of summary slides. We have a listserv that's available for anyone, and it can be accessed on the AHRQ website. And the screenshot here shows that you sign up for an email update in order to get information on webcasts or data submission timelines, any other products. And you simply sort of choose this tab on the web page, and then you can select to receive emails associated with CAHPS, and you're signed up. And it's a very helpful service for receiving information on an ongoing basis. We also recognize that there are going to be questions that come up, and we will always be available to answer them on an ongoing basis, and not just in the form of a webcast, but we have a technical assistance line that's handled through email at this address, caps1@westat.com, by phone at 1-800-492-9261, and of course our website again, which is www.ahrq.gov/CAHPS for CAHPS. We also just, really want to thank all of you again for the interest you've shown, for showing up for today's webcast. We ask that you fill out a brief evaluation that pops up when you close out from the webcast today. Your feedback helps us, as we're all collecting feedback from our various audiences to improve what we do. And so we invite you to also visit the AHRQ website at any time and get in touch with us at any time through the various channels that we've described. And again, we want to thank you for joining us and wish you a wonderful rest of your day and all the best for the holidays and a new year in 2021. Thanks.